that as people are joining, I just want to say thank you. I want to remind everybody to open your chat window, add your name and organization and where you're from. And I just want to thank you for joining us today. The Northland Diversity and Aging Series team is really excited to have you, and we're excited to offer the second event today. I want to just note, if you have questions and answers or questions at any time during this, or anything you'd like to pose to our panel of experts later on, that you go ahead and put those in the Q&A session and not the chat. We'll try to monitor both, but those Q&A, the Q&A session has a better chance of us seeing it right away and being able to ask it. I also want to note that later on in this presentation, we're going to do a couple polls, and we won't be populating the answers for everybody. Those polls are really just to help us with future planning. And so I'm just going to thank you in advance for completing those, and glad to see you all here today. Thanks so much. If we're ready, I'm going to pass this off to my co-host, Amy. And then before I do that, I guess I should say I'm Christy Kane from the Arrowhead Area Agency on Aging. I'm stepping in today for Georgia Lane, who was scheduled to co-host this with Amy. And so you're going to forgive me, hopefully, if I'm a little rough. But I'm going to pass this off to Amy Bergstrom.
Sounds good. Thanks so much, Christy. And thank you everyone for joining us this afternoon for second in our series, the Northland Diversity and Aging series. My name is Amy Bergstrom, and I serve as the Chief Diversity Officer at the College of St. Scholastica. And we're just really delighted to be a collaborator in this important event and in this series overall. And it's really a joy for me to be in this great company with all of you, and to be a co-moderator this afternoon with Christy. Before we get started, I would like to present a land acknowledgement that was provided to us from the Northland Foundation, who is a collaborator in these events as well. And so I will just take a minute to sort of center us, if you will, in terms of recognizing the land in which we reside on here locally, and also thinking regionally. So the Northland Diversity and Aging Series team recognizes the land we currently live and work on originally was and continues to be the homelands of Indigenous people. We currently enjoy access to this land because the land was ceded in a nation-to-nation treaty process between the Anishinaabe and the United States government. By recognizing Indigenous homelands, we accept our shared history and make a commitment to shape our ongoing relationships with justice and reconciliation as our guiding values. So thank you, Northland Foundation, for sharing that, those important words with us to share today. We're, as Christy mentioned earlier, we're just going to be putting up a brief poll here for you, just to give us a little bit of a better understanding of who's in the room with us. And so if you could take a minute to answer, the questions that are in the poll. And if you can scroll down in the chat, it looks like there is an opportunity for that. I don't know, I don't see the poll open yet, but here it comes. So just some questions that help us in understanding who's with us today. So just really some simple questions that give us a better understanding of who our audience is today. So Christy, I think we'll just give them a moment to finish the questions on the poll, and then I'll turn it over to you for our opening remarks and our introduction for our keynote presentation.
That sounds great. Thank you, Amy. Great. It looks like everybody's voted. Well, thank you, Amy, for that. And hello and welcome everybody to the Northland Diversity and Aging, Rural Aging and Caregiving event. This is the second event in our series that examines diversity in all its forms as it pertains to aging in rural Minnesota, and particularly in the Arrowhead region. We're here today to discuss why the rural aging and caregiving experience is important to examine. And my name is Christy Kane. As I noted earlier, I'm the director of the Arrowhead Area Agency on Aging and a proud partner in this work. Together with the Northland Foundation, Duluth Aging Support, the College of St. Scholastica Gerontology Program, and their Office of Equity, Diversity, and Inclusion, we're excited to bring you this series. The Northland Diversity and Aging series is an intentional space that seeks to ignite conversation and promote learning across generations and cultures about the aging journey. As Dr. Hauger from the College of St. Scholastica noted, if we're going to support caregivers, then we need to have an awareness of the diverse caregiving experiences and needs of our neighbors. We know that healthy aging in our communities touches everyone, and it's everybody's responsibility. You and I have the ability in our lives, in our community, and in our sector to support the journey of aging and positively impact others on this journey. After all, we're all aging, and aging touches every community, every person, every service, every job, every sector. We are truly in this together. The Northland Diversity and Aging series team recognizes that there are countless ways we age differently from one another. Cultural diversity is a primary factor. Cultural diversity can include language, religion, spiritual beliefs, race, sexual orientation, gender, age, and ethnicity. There are many other experiences that shape our lives and make us and our age experience different from one another and unique. Some of those things are social economic background, trauma and crisis experience, family background and history, educational background, mobility or disability status, where you live, your neighborhood, characteristics of your housing and types of housing and access to basic needs like food, transportation, healthcare, education, social connections. To truly appreciate diversity in aging, we need to be sensitive and aware of the intersection of these differences, and we need to value how individual experiences impact each other. Our commitment through this series is to inspire discussion around ways that we can all support and create opportunities for the contributions and engagement of all older people in our communities. In the last decade, the number of people in the United States over the age of 65 has increased by 36%, compared to only 3% for those under 65. The median age nationally in rural areas is 51 compared with 45 in urban areas. And for many areas in the Northland, 1 in 5 people are over the age of 65. In some areas in the Arrowhead, that number is 1 in 3. This poses a challenge for those living in our communities in terms of providing supportive services and providing care to our neighbors who need additional support. In 2000, there were 32,068 people in the region who were 55 to 64 years old. That age group has increased by nearly 60% since then. Likewise, the number of people aged 65 and older in Northeast Minnesota has increased by 23.4%. Those are staggering and growing numbers in our region. At the same time, an aging population creates a stronger demand for healthcare and social services. According to the Minnesota Department of Employment and Economic Development, healthcare and social assistance jobs in Northeast Minnesota are projected to grow by 10.7%, and they make up 22.4% of overall employment in our region. By comparison, the working age cohort in the Arrowhead is seeing a 12.4% drop in people 14 years or younger. So this paints a future in which it is difficult to replace retiring workers. In addition, within these statistics around aging demographics, great disparities exist. In our first series, Mimi Stender from Duluth Aging Support pointed out that healthy aging in the Arrowhead depends on several factors, including where you live. In St. Louis County, there's an 11-year life expectancy difference between zip codes. She reminded us that some of the very ways that make living in the Arrowhead special and unique may challenge our quality of life as we age here. We know that rural areas have the highest concentration of older adults and nationally are aging faster than urban areas. This means that as our population ages, the highest concentration of older adults may have access to fewer healthcare services, and they may face longer travel times to obtain care. All this seems daunting, but we are equipped to make changes, and those changes start with conversation. Let's work together with our region, with our neighbors, to create spaces where we can improve our ability to maintain physical, emotional, and social well-being for everyone. Consider your interactions with people older than you and ask yourself, what are your connections? How can you do a better job engaging with your older neighbors? What is your role in making our communities age-friendly and a better place to live and age well? Today, we'll explore the demographics of aging in Minnesota with an emphasis on Northeast Minnesota. We'll talk about the barriers to maintaining well-being as we age, unique challenges that face our Native neighbors, and ways to overcome them, as well as resources available to support caregivers and meet their caregiving goals. With that, I have the privilege of introducing our keynote speaker, Megan Dayton. Megan is a senior demographer joining us from the State of Minnesota Demographic Center. And I just want to thank you, Megan, for being here today. We're truly grateful for your time and attention to this important topic. I'll let you introduce yourself and tell us a little bit more.
All right, thank you, Christy. I almost said good morning, so it's right in that transition phase. I will say good afternoon, and thank you for having me here. My name is Megan Dayton. I'm a senior demographer at the State Demographic Center, where I've been for about 10 years, traveling around Minnesota and talking about trends that are happening in and around our state. Minnesota is relatively unique in that we have this one metro area where a good portion of our population is concentrated, but we have those 80 counties in greater Minnesota that our office in particular focuses on. So it's really fun to travel around and sort of offer the denominator for a lot of work that's happening around greater Minnesota. If we go back all the way to the 70s, that was when these state demographic centers or state demographer offices came to be. And it was a result of the baby boom generation, the end of the baby boom generation being born, I should say. So we've been talking about and trying to talk about this trend in aging, as you'll see in my presentation, for some time now. So it's really cool. I wasn't around in the 70s, obviously, but it's really interesting to see how many connections are being made, in particular with aging data in our state. So I'm not a native Minnesotan. I grew up in Michigan, and I say that because I feel that it's quite relevant in my exposure to demographic trends. In Michigan was the only state in the country to lose population between 2000 and 2010. So I was watching folks leave the state in record numbers, and my connection to demography began, I think, at that point, but I didn't study it formally until I got to college. I'm here now in Minnesota. I married a Minnesotan. I birthed 2 of them, so I've demographically replaced myself at this point. And it's really, like I said, it's really fun to travel around and talk about trends that are happening in Minnesota from somewhat of an outsider's insider perspective. So I do have a ton of slides today, and I might go pretty fast, but I'd like to just jump in and get into them. So let's talk a little bit about the 2020 census. On a national scale, Minnesota grew by about 7.6%, which was right on with national trends at 7.4%. So we grew just a touch faster. And we did really well, considering that our neighbors in the Midwest and the Northeast are growing much more slowly. And some of them, like Illinois, have declined in population by 0.1%. That 0.1% doesn't look like a lot, but the population of Illinois is fairly large. So that was a decline of about 150,000 people. So this tells me a couple of different things. First of all, we kept our 8th congressional seat by a number of 85 people, which I didn't even know was possible. It's a fraction so small that I won't bore you with all the zeros here today. But we're seeing this shift in population from Midwestern and Northeastern states and to Southern and Western states. This is a trend that we've seen throughout the whole decade of the 2010s and 2020s. And I believe that this is a function of an aging population overall. We still have this decennial census that can only count people in one place at one time. So wherever you are on April 1st, that's where you're counted. If you have a home in North Dakota and Texas, for example, if you're in Texas on April 1st, you're counted, your political representation, your funding is moved to Texas rather than North Dakota. So I think some of this is somewhat of an artificial shift in political representation. As our population ages, we are highly mobile. This was probably the most difficult census that we've ever encountered. But we did continue growing. We did well along with North Dakota and South Dakota compared to our neighbors. And this is a really interesting part. We have only the redistricting data from the 2020 census so far, but there are broad race groups and ethnicity included in these data that have been released so far. You can see that Minnesota crossed that 5.7 million mark in 2020, which is exciting. We grew by about 400,000 people over the course of that decade. And for the first time in our history ever, Minnesota's population of white non-Hispanic residents declined by about 50,000 or 51,000 people, but that's the first time that that's ever happened for us. And what that means is that all of our population growth over the last 10 years is fully attributable to Black, Indigenous, and people of color, folks who identify as Black, Indigenous, or people of color. So you can see there's some big differences in those growth rates. The Black or African American population is still the second largest cultural group behind white non-Hispanic, but we've seen absolutely incredible and exponential growth in that 2 or more races down there at the bottom, which we can phrase that somewhat more simply as multiracial. Now, because we only have the redistricting data at this point, we're not sure if that's actual growth or a change in the way people are choosing to self-identify. So we need some more data to see what's going on there, but some really remarkable things happening overall in terms of growth by the major race groups here in front of you. So let's talk about population growth just overall, and then I'd like to get into trends in aging, tie that into diversity, and we'll do just a little bit on the workforce if I can talk fast enough. So here's the county level growth, all of our 87 counties, and you can really see that those dark blue colors, those are counties that are experiencing population growth over the 10 years, and they're really concentrated in the metro area here. The orange or the Manila colored counties are places that are experiencing population loss over those 10 years. Big gains in the counties that are experiencing gains, and modest losses, very modest losses in the counties that are experiencing loss. Overall, 51 counties grew over the course of the decade. 36 counties experienced loss. And again, we grew by 400,000 people. So the gains outweigh the losses. So trends in aging. I really like to drive this home. This is the basis of what we're talking about here. From the 1950s to the 2000s, the growth in the 65 plus population was fairly stable. It was really reliable. And this is what I was talking about back in the 70s. We had this huge population of people born into the generation that we call baby boomers. And a lot of these demography offices popped up to study this trend and sort of warn lawmakers and decision makers that we need to start talking about this now. So we've been sounding the alarm that this is something that we need to focus on. It's also a function of the calendar, right? You have to get 1 year older every 12 months. I've been trying to stop it for, I don't know how old I am anymore, but for that long, and it's not working yet. So demographers can see this coming from a very long way away. It moves at a glacial pace, right? But it's pretty reliable over the last 6 decades or so. In the decade that we just left and the decade that we're currently in, we will add the same number of 65 plus residents to the statewide population that we had in the last 4 decades combined. Just that number for the 2020s that are in, that 335,000, that's more than the total residents we added to the statewide population between 2010 and 2019. So it's really, really incredible. And I think what we're here to talk about today is not so much related to what's in front of you, because it looks like we just go back to business as usual in the 2030s, 40s, 50s, but that's really not the case. What we're talking about here on the screen is 65 plus, but we're not going to go back to this business as usual or this normal age structure. We have truly transitioned to an older Minnesota, because if you think about, if you shift this out just 20 years to say 80 plus or 85 plus, The same bars exist just 20 years out. So we really need to change the way that we're thinking about this transition to an older Minnesota. So this is actually moving in front of you. You're not seeing things, it's supposed to be moving. This is a population pyramid of the state of Minnesota between 2010 and 2018. We have single years of age. So our babies are on the bottom, our oldest Minnesotans, 85 plus, are on the top, and every line in between is one single year of age. We have females on the left, males on the right, and that orange portion of the population pyramid, that's our baby boomers, born 1946 to 1964. And what I really want to highlight here is the dissimilarity. The boomers have started to move into higher mortality ages, so it looks like a smaller generation than it used to, say, 30 years ago. But the real challenge here is not necessarily that the boomers were such a big generation, it's the dissimilarity of what came after, the Gen X generation, so 1965 to 1981. That generation was much smaller. Sometimes it's called the echo generation, which means not only do we have to plan for the boomers, but then we have to plan for the Gen X that comes after it because of that dissimilarity. So I just wanted to highlight that for you. And then what comes after is the millennial generation, Gen Z after that. And we do see a leveling off of the size of the generation overall. So here's a timeline of what that looks like. The first boomer turned age 65 in 2011. The last boomer will turn age 65 in 2029. And we're right there in the red, right in the middle of this transition to boomers leaving the workforce in record numbers. But again, that's not the end of the conversation. We shift this out 20 years. Our first boomer will turn 80 in 2026. So that's just 4 years away. And our last boomer will not turn age 80 until 2024, right? So we're not really even in the middle of this trend yet. A lot of people think, woo, we're done. They've seen this first wave come through. But we are truly in the middle of this transition to an older Minnesota. And when we do that shift from 65 to 80, we're changing the conversation to what types of care folks can receive in their older ages and where they can receive it, which is why I'm so excited to be here today to talk about rural care in specific. So let's get back to that. So real quick, some trends in diversity as it relates to aging, right? I like to talk about the foreign-born population in Minnesota. It doesn't always translate to people of color, but it does contribute to the diversity of our state, and it really relates to the oldest generations that we have in Minnesota and the baby boom. So 1920 to 2020 here, 2019 in front of you, the numbers look very similar for the size of the foreign-born population in Minnesota. In 1920, it was about 490,000. In 2019, it's more like 470,000, but very similar considering the changes that we experienced over the last 100 years. The difference is that in 1920, 1 in 4 people in Minnesota was foreign-born, whereas today it's only 8%. Oops. There we go. So we can look at where these folks are coming from too, the country of origin, which describes the just boom in diversity that we've experienced since the 1980s. If you go back to the turn of the century in 1900, 1910, 1920, we had 3 primary sending countries into the state of Minnesota, and those were Germany, Sweden, and Norway. So particularly Scandinavian countries, Caucasian identifying people made up the foreign-born population in our country. We still see relics of that today, but if you look, after that is what I call the Scandinavian ski jump, because that's what it looks like to me, to where we get the bottom point in 1980 for those 3 sending countries. But what we experience thereafter is this boom in sending countries. You can see the incredible growth of the Mexican-born Minnesota population from 1990, particularly through 2010. That's still the largest population of foreign-born folks that we have in Minnesota as Mexican-born, and it's about 66,000 folks today. You can see Somalia has just crossed over India for second place in foreign-born folks. And then India, obviously, we have Laotian or Hmong population, and Ethiopia, and we do still see Germany is at the top of the list there. So there's a big difference in the way that our foreign-born population identifies themselves in the state of Minnesota. So as these folks age, it's not particularly going to be made up of those Caucasian identifying folks anymore. So here's really what that looks like, and this is the momentum that I want to talk about. This is another population pyramid that we have. Our babies are still on the bottom. Our oldest Minnesotans, 85 plus, are still at the top, but the lines that you see in between are 5 years of age rather than single year of age. So the blue portion of the bar is folks who identify as Black, Indigenous, or people of color, and the green portion of the bar is the white non-Hispanic population in Minnesota. So up at the top, our 85 plus population, only 5% of those folks identify as Black, Indigenous, or a person of color. But the line, the blue portion of the line gets bigger and bigger and bigger every line that you go down to. At the bottom are babies, 32%. 1 in 3 babies born today in the state of Minnesota is born to a mother who identifies as Black, Indigenous, or a person of color. So we see, you can tell that the parent population will continue to get more and more diverse every year. Let me say that the other way. The child population will continue to get more and more diverse every year because the parent population continues to get more and more diverse every year. So if we close down our state borders, if we close down our national borders and we just lock everybody in place, our population in Minnesota will continue to get more and more diverse, no matter what we do, because there's this momentum to diversity that's already baked into our age structure. So you can imagine this going up and up and up as we age the population more and more. So we can look at the labor force too, particularly in greater Minnesota. So these are the 3 major age groups that we talk about interacting with each other in terms of public dollars that typically make up our society today. So at the top is the working age folks, working age adult population, 18 to 64. You can see pretty strong growth from 1960 all the way through about 2010 when it leveled off. The line just under that dark blue is our child population under age 18, which really leveled off in 2000. And then the retiree population, age 65 plus, is the green line at the bottom, which started exploding in 2010 through 2030. In 2040, I'm not sure if you can see my cursor here, but right here in 2040, this is another momentous event for the state of Minnesota, where we anticipate for the first time ever, our retiree population, age 65 plus, will outnumber our child population for the first time ever, right? So this is a real shift in the way that we're talking about public expenditures, from primarily dominated by K-12 education and into healthcare support like Medicare and Medicaid, things like that. And I think this is the really interesting slide here that I wanted to end on so that it sticks in our mind as we go into this panelist discussion. But we have seen just incredible growth in the 65 plus population. I've touched on that quite a bit here in my presentation. But here's what it looks like if we talk about the metro versus greater Minnesota in terms of the change in our state. So we still have these 3 big age bands: the child population under age 18, the working age population 18 to 64, and then the 65 plus population. So really incredible growth in greater Minnesota of about 21% over the 8 years, 2010 to 2018. But what I see, what stands out to me here, is the decline in the child population and the working age population in greater Minnesota. So this incredible growth that we're seeing in 65 plus in greater Minnesota means that people are choosing to retire in place in greater Minnesota, which is great. But if this trend continues, where we continue to see decline in the child population, in the working age population, as these folks age, there will not be the support services or the economy for folks to retire in place to continue receiving healthcare services in greater Minnesota. So we will have to shift folks to the metro if these trends continue. So we do still see really strong growth in the metro. So some folks are choosing to come to the metro for care or for their retirement, for their transition into retirement, but we do see growth still. And what I would consider fairly positive growth in the child population and the working age population for the metro area. Now, we have seen some changes to the way that this is going potentially coming out of the 2020 census, meaning that through the pandemic, some folks have been freed from their workplace or freed from going to campus for educational opportunities. And perhaps that shift can support people living in greater Minnesota, but working in a place, virtually, like the Twin Cities or another metro area, but supporting the local economy in a place that they typically would not have access to without virtual work that we have experienced over the last 2 years. So really interesting things happening here, where if these trends continue in the decline of those two populations, child and working age, in greater Minnesota, folks will not be able to continue to retire in place as they have very obviously done over the last 8 years. So just to leave you with a couple of takeaways, because it's a lot of data, it's a lot of charts to throw at people in just 20 minutes here. But in general, when we travel around as demographers, the three of us in this state, we like to talk about three major things. The shift in the size of the school age child population to older adults, 65 plus. This is that shift in resources that I was talking about, both public and nonprofit, away from being dominated by K-12 education and into the need for healthcare services. So this will impact education and training resources to fund these opportunities. And then the slowing labor force growth that we didn't really talk about too much here today, but I think it's really important for greater Minnesota to consider that training and retaining workers in greater Minnesota will be essential to future economic growth in those places. And then this increasing diversity that has its own momentum baked into the age structure that will impact our future generations aging in place potentially and hopefully. So that's what I've got here today. And I think I will hand it back over to Christy and just thank you again so much for having me here.
Thank you, Megan, for that fascinating presentation. And I think we've all been eager to see some of the census data wrapped up and presented in a tidy little bowl. So I really appreciate you being here today. Please also note Megan's going to be staying and joining us for the panel discussion with our regional experts. And I'm going to go ahead and introduce Dr. Joe Bianco, family medicine physician in Ely, Minnesota, is with us today, as well as Marie Spry from Grand Portage. She's a Grand Portage councilwoman on the Tribal Reservation Council, and she's the executive board chair for the State of Minnesota Wisdom Steps program. And finally, we have Christy Wagner-Werner, who's a caregiver and dementia consultant with Kuching Aging Options in International Falls, Minnesota. Thank you all for being here today. We're excited for this conversation. I just want to note again, I see we have one question in the question and answer session box, but just remind people to please put your questions there instead of chat. And we're going to start out, and I'm going to start with you, Dr. Bianco. If you would just please introduce yourself both personally and professionally. Tell us what brings you here and why you're passionate about the rural aging and caregiving experience and why this matters so much.
Yes, thank you. Thank you. Good afternoon, everybody. Yeah, my name is Dr. Joe Bianco. I grew up in a small town, Silver Bay, Minnesota, and have been working in Ely, Minnesota for the last 30 years as a primary care physician. I also had a role at Essentia Health as being the director of primary care for the past 15 years. Currently, I'm now working on issues of addiction, opioid use, and substance use in rural communities. So I've always lived in a rural community, and I've always valued the environment of raising my family in a rural community. Much of my work right now in the primary care world, obviously, is looking at these changing demographics that Megan has just outlined, as we're seeing more and more elderly, more and more of our older adults needing care, and that we need to change the way that we deliver care in order to meet the particular needs of those individuals. It is our obligation within the healthcare world to recognize exactly what has been outlined. And like I like to say in northern Minnesota, because we're getting into the season of the hockey tournaments, we got to skate to where the puck is going to be. And that's what we need to do. We have a lot of smart people on this call here today who can help us develop models of care delivery to meet these challenges.
Thank you, Dr. Bianco. Marie, would you mind telling us a little bit about yourself and why this issue is important to you? And you,
I better unmute myself here. I'm a central caregiver for 2 of our elders from Grand Portage that are in the care center in Grand Marais. We do not have assisted living or anything. So when our people get too old, they have to leave. And that's really sad, you know, so I do what I can. My husband and I raised our kids in Silver Bay, actually, same as, and we came back home about 23 years ago. So tried all that way. There was no work up here. When we got married in 67, there was no work. So we had to follow construction, and we landed in Silver Bay and stayed there and raised our kids. I have 18 grandchildren, 2 great-grandchildren, and 6 children, 1 girl and 5 boys. We had 4 of our own children, and we adopted 2 more boys. So we have a little puppy. Her name is Maggie, and she's 16 years old. And I've been on the tribal council since 2012, and the Wisdom Step State Board too since 2003. But I'm the 4th term of being the chairwoman for this all 11 reservations that represented by Wisdom Steps. So I don't know what else.
Oh, that's perfect. Thank you, Marie, and thanks for being here with us today. And Christy Wagner-Werner, we'd like you to tell us a little bit about yourself personally and professionally, and what brings you here, and why you're passionate about rural aging.
Good afternoon. My name is Christy Wagner-Werner, and I am a caregiver consultant with Kuchaching Aging Options in International Falls. I have been acting as the consultant for the past 5 years, in addition to a dementia consultant and coordinator of our Memory Cafe support group. I was born and raised in International Falls, left for a brief time for higher education, where I graduated from Bemidji State University with a Bachelor of Science, double major in administration and management. And I always say I was one of the fortunate ones that could return to our community here in International Falls, where my husband and I raise our 2 children, ages 14 and 9. And when we're not at a hockey rink or a dance studio, we enjoy spending time at our cabin on Rainy Lake and the wonderful outdoor opportunities that northern Minnesota offers. I'm truly passionate about the rural caregiving community from the standpoint of empowering caregivers to be able to see that they can really lead a high quality, fulfilling life in their caregiving role, even with the limitations that a rural community offers. And this goes a little bit deeper into a conversation we'll have when we get into our panel discussion about the creative solutions and creative thinking that we need to pull for as a rural community to be able to allow these caregivers really to truly thrive rather than just survive in their caregiving roles. Thank you so much for having me. I'm delighted to be here this afternoon.
Great. Well, thank you all for that wonderful introduction. And I'm going to transition us a little bit to some of the questions that we have for our panelists, our main questions. And Dr. Bianco, this first one is for you, and it's kind of talking about barriers, if you will, and What do you think are the greatest barriers to maintaining your well-being as you grow older in a rural community? And the second part of the question is, and what innovations are there to break down those barriers that keep rural older adults from being well?
Okay, well, so when we look at well-being for our older adults, I like to break it down into the emotional, the physical, spiritual, and social. Okay, and I think it's important to recognize in our rural communities where each one of these issues, where the challenges are. Obviously, emotionally, because people might have more social isolation, and I really do see loneliness as a chronic disease, and there's great data about how loneliness can affect our physical well-being. That is oftentimes as a result of geography and changing in our populations that we're seeing. And oftentimes, as was noted too, we're seeing family groups being split up more because of the economic challenges that are in our rural communities. Young people have a harder time finding work, even at whatever degree of work, and end up moving away, leaving their parents to be by themselves in their rural communities. That's one of the changes that I think Megan was pointing out as well. Physically, we're, most of us as we grow older will develop some form of chronic disease. And as we, and that means, when just the definition of chronicity means that it needs attention on a regular basis. And the models of care that we've developed that have been going on since my grandfather started delivering care in West Duluth in 1920, it's the same type of model. There's a clinic, there's a waiting room, there's an exam room, and then there's some kind of caregiver. That model hasn't changed a lot. Now, luckily, it sounds kind of funny, but the opportunities came with the COVID epidemic for care models to be changed and innovation to come forward in regard to how we can see people. And I think what we're looking at right now, we're still discovering what that impact was. And if there wasn't a big change, how we bring those types of innovations forward in doing that. Furthermore, in regard to behavioral healthcare, which we know in the rural communities, we do not have the number of people to provide services in regard to behavioral health care. These types of innovations can also be quite effective going forward. I also think some of the very fabric of our smaller communities have traditionally been in the past our social organizations as well as our spiritual organizations. And we're also seeing less participation in the younger generations going forward in regard to that, and also as the demographics change within these communities in order to continue to keep the Kiwanis and the Lions and our churches going with income to keep these institutions going. We see the loss of that fabric and people being able to get together and do good work within their communities. So as I look at solutions, I think it's really important for us in healthcare. And I like to think of things in this way. I like to think of things in regard to capacity, in regard to burden, okay? Every day we wake up, all of us do. And we have somewhat of burden that we have to do for the course of the day. We got to get to work, we have to get food, we have to do this, we have to do that. That's the burden of the day. It's fine, but it's the work of the day. But for older adults, we see our capacity diminishing to a certain degree, right? That's just the reality of what goes on. So it is our obligation within the healthcare world to try to decrease the burden. If you're ill in the middle of January in Ely, Minnesota, it's hard to get up, get dressed, go to the clinic, sit in a waiting room, sit in the exam room and be seen, especially when you're not feeling well. So the innovations that need to go on are to lessen the whole burden of how we deliver care. We've started to do video visits in which we can get online with folks. Again, a lot of this innovation depends on connectivity within our rural community. And if we're able to increase and improve connectivity and make it affordable, then I believe we can deliver these new types of innovations, such as video visits, home healthcare monitoring, in which directly downloading healthcare information to a centralized location, in which we can then see how people are doing in regard to blood pressure, pulse, respirations, temperature, that type of thing. We have now started doing hospitalizations at home. Instead of people having to come into the hospital, we are able to do a certain level of care within their home, where traditionally people would be in the hospital, but being able to have them at home with home monitoring equipment, where we can do rounds on them through telehealth every day, be able to provide services for those folks. Studies that have been done in this regard have showed that the level of care, people do better. There's less complications. They get, like I said, they get better faster. They're more mobile. We don't have problems that often happen when people are outside of their normal settings in the hospital, such as delirium and confusion and falls in the hospital setting. So being able to do these types of innovations, I think are really important. Furthermore, not only within the rural communities are our patients growing older, but our staff is growing older, our clinicians and our nurses, right? So if we're always relying on the delivery of healthcare to only a physician, and that's how we measure everything, we're going to be in trouble, right? And particularly because primary care, there's a lack of primary care clinicians as well. So being able to right size our healthcare teams with professionals who might not be physicians, but RNs and nurse practitioners and physician assistants and other types of healthcare providers, I think it's really important. So creating a diverse primary care team so that not everything runs through a physician. It can run through an empowered team to give the right type of care with the right amount of care by the right person to our patients in a fashion that can be mobile or virtual going forward. I think that is how we can meet some of these challenges. Finally, on the upstream side of things, looking at our communities and community leaders to say, how do we keep younger people here? Or now that we know that so many more people are doing their work by televisits or virtually, how do we attract people to these wonderful places? Obviously, I live in a wonderful place of Ely. And when the pandemic hit, I had my college student from Maine home doing all of her college. I had her boyfriend home doing all of his college. I had my daughter, who is head of healthcare policy for the state of Massachusetts, doing all her work from home. I had her boyfriend at home, and I had my son, who is in high school, doing work from home. So we were all doing this work from home, right? Well, there's a lot of people who recognize that the urban environment really isn't for them, because they all came back to that. And so communities have to attract folks in that sense to come back, increase the tax base, invest in recreation centers, community centers, healthcare centers within their community, invest in schools so that will attract people to come as well. That way you build up that small rural environment that leads to being able to deliver all these services to our aging adults.
That's great. Thank you, Dr. Bianco. Some fantastic things, and it sounds like you had quite a household during last year.
Yeah.
I'd like to ask you, Marie, can you speak a little bit to what some of the challenges facing our the Native people in your community are?
Well, where we live, you have to travel a lot. You have to travel a lot to school, but back and forth to school. And with the weather we've had the last few days, we have lots of snow here. Roads are terrible. Shopping, we used to be able to go to Canada in 40 minutes up to go up. They could go to Walmart or one of the shops up there and shop. And now it's the closest is Duluth, which is 150 miles. You know, that's one thing. Not everybody can afford a vehicle. There are people that don't ever get out of the village, especially the elders. Since the pandemic, the Elders Advisory Committee here in Grand Portage has not been able to go and get the elders, take them on a weekly shopping trip to Grand Marais, monthly shopping trip to Thunder Bay or to Duluth or anything. Everything stopped and they haven't gone anywhere. We have had one chore worker here for the elders who retired because she's an elder too, and nobody has applied. You know, the young people that we've had working up here for our enterprises, they went to Duluth and other places because they would get more money. You know, it was easier to live. So like I said, there's transportation, mileage, it's all pretty tough up here for a lot of people. When us on the tribal council, when we travel too, you know, a lot of times we'll take people with us, you know, so you can go shopping while we have meetings and things, you know, but you can't take everybody. You know, it's crazy. The kids that want to play sports in school too, they have to have parents drive them back and forth because we don't really have a bus for them after hours. And the Native kids are all very athletic and want to be included in all these things. And it's tough. But because of the pandemic, I think before that it was a lot easier. I'm not sure what else. I could go on for 2 days, but that's okay.
That's wonderful. Thank you. You definitely shed light on a very real challenge, you know, the transportation piece. The next question is for our panelist, Christy, and thinking about resources. And so if you could speak to, you know, this question: in a rural community with limited resources, how do you best support rural caregivers to sustain and meet their caregiving goals and needs?
Sure, thanks, Amy. So, you know, I always reflect and think, even when resources and supports are plentiful, the caregiving journey can still present many obstacles and challenges. So when we look to a rural community where those support channels and resources are much more limited and restricted, this obviously leads to greater barriers and challenges for these caregivers to sustain. Oftentimes, I remind my caregiver clients, you know, we're really pacing for the marathon here and not the sprint in our caregiving journey. And the appropriate supports are so critical, both informal and formal supports, to be able to pace for this journey for the long run. When asking my caregiver clients a lot of times what their caregiving goals are, one of the most common repeating patterns I hear is the caregiver wishes to care for their loved one in their home as long as possible, or as long as they are able. So this is where it can get tricky when we are dealing with a limited spectrum of support. If we look, for example, at our International Falls community, just to paint a little picture for you all, I mean, we have one hospital, 2 small clinics, a small home health care agency. There's absence of formal respite services or formal adult day services, absence of formal homemaking services. We have one major skilled care facility, which does not include any memory care unit or facility. So when we look at these limitations, how do caregivers sustain? And we often have to resort to what we call creative thinking and creative solutions for these caregivers to be able to meet their caregiving goals. Where do these creative solutions come from? I truly feel that the solid community collaborations across multiple agencies is one of the most critical pieces and ensuring that supports are available for the caregivers, the care receivers, and their families. These relationships with multiple entities, and this can be from our local clinic providers to our county public health and human service offices, our skilled care providers, our homeless shelter, our food shelf, places of worship. These relationships with these agencies take time to establish. They take time to maintain them, but they're truly priceless. It's really essential to be able to trust and connect across the spectrum to ensure that we are able to support these caregivers with meeting those goals, and again, sustaining for that marathon and not that sprint. And these cross collaborations, honestly, are what make these creative solutions possible. So while it appears that caregiving in a rural community, yes, can be certainly more challenging with more limited resources of support, I also look to it as almost a shining light where in the small community, specifically even where we are, these many trusted collaborations that run so deep and being truly committed as a whole to serving and supporting that rural caregiving community. I was thinking about several of my caregiver clients and these cross collaborations that really generate these creative solutions for caregivers to meet their goals and sustain. And I had one caregiver client that really kept popping up in my mind. So I was just going to share a brief story with you all on how these cross collaborations really ran deep and helped this caregiver in their situation. So this caregiver, it was a referral from a local clinic. We have referral systems set up to our agency with both of our local clinics. She was caring for her husband who had an Alzheimer's diagnosis. She'd been caring for him for about 8 years at home. On our initial conversation, she was quite resistant to, any sort of support, was really going to handle this all on her own. And in recent weeks after that initial conversation, the caregiver herself had actually received a diagnosis of a mild cognitive impairment, where we began having conversations again. She had reached out on several occasions and was truly acknowledging that providing care for her husband in the home setting was not only becoming more challenging for her, but her recognizing that she was no longer meeting his needs at home. So we assisted her in meeting her caregiving goal, which was ultimately to transition her husband to a higher level of care at a local skilled care facility. We worked specifically and directly with the skilled care facility. We organized tours and placement. We worked with county public health and human services on the financial assessment piece. And while all those long-term plans were coming to fruition, we worked on some of that short-term goal meeting for her. How was she going to sustain in the home while this long-term plan came into place? We cross-collaborated with, grocery delivery services and Meals on Wheels. We came up with an informal respite calendar for her. We were able to help her locate private homemaking services. Again, all of those things for her to be able to meet her short-term caregiving goals in the home while those long-term goals were coming to fruition. And from the time our initial conversation started to when actual placement for her husband happened was just under 6 weeks. And, I think that reflects and shows that those strong cross collaborations and relationships with the multiple agencies in our small rural community, where we all really came together and assisted to be able to offer those long-term goals and solutions for her. And again, this was just one example that had surfaced in my mind. And again, while we look to this as what we would consider a barrier or an obstacle in a rural community with the absence of services, truly again is that shining light where these trusted collaborations that run so deep, and when you are truly committed to that whole, where you can still see things happen.
Well, thank you for that, and thank you to each of you for your your insights here for that. We're going to go ahead and transition now to our Q&A session, and there's some really great questions in the chat. And I'm going to go ahead and take the first one, and Christy and I will work together here on getting the questions out here. But the first question is on population growth. So I think I'd like to, if Megan would want to address this, but the question came in, why is population growth often seen as a positive when really isn't that the problem?
That's a great question. That summarizes my master's degree in one sentence. So thank you for that conciseness. But yeah, I mean, that is the real question. The view of population as a positive, I think, relates to the tax base, right? There are people who will become employed and will pay into public services that are necessary to support people. But people are also expensive in terms of dollars and space and things that we create and throw away. And so what is that balance? And I think there are some global organizations that focus more on what is this balance as we approach 8 billion people on this earth total. In terms of what we can sustain, but a lot of that depends on how we live. And here at home in Minnesota, that we talk about that in terms of climate change, people leaving coastal areas in the United States and coming to inland states like Minnesota, and how are we going to handle the people that come here? So it's a great question that I don't have a great answer to because we don't know what that balance is yet.
Thank you. Thank you, Megan. I see another question in here, and I think this is broadly addressing probably all of our panelists. The question is, what are we going to do about the cost of prescription medications? For example, American Indians and African Americans are at a high risk for diabetes and related major health impacts. My husband is Anishinaabe elder and thankfully receives his insulin through Indian Health because he is an enrolled member and eligible for this and other wonderful care from the tribe. A dear sister friend is an elder Black woman living in a North Shore town and has consistently had her prescription insulin denied by an insurance company. There's no network of support for her. She's also dealing with a husband in late stages of dementia, which has put an additional strain on her. But doctors keep telling her to reduce her stress, not realistic without some meaningful help. And maybe if each of our panelists want to speak to that, I would maybe just start out with you, Marie, if you would want to make a notation, and then Dr. Bianco and Christy.
I have friends that are native here in Grand Portage that are diabetic, and they have to have that insulin, and that's with our traveling to our pharmacies in Grand Marais or Duluth, wherever. If the mail gets held up, there it is, and they will not send it to them early. Like this is her last day, and she was supposed to have gotten it, and she didn't get it. So that's what's awful about living way up here as far as prescriptions go and things. I don't know. I don't take any of that stuff, but which is, thank God I don't, but I'm very lucky. My husband is too, except he's a health nut. So he wouldn't take anything anyway. But yeah, it's hard living here, trying to get things on time and stuff. And I do know that my friend was without her insulin for a whole day, which she takes two injections a day of that, and that's just really sad. And then there was another thing too about I think it was Zyrtec and EpiPens that they were not, the insurance was not going to cover. It's expensive stuff. But they did figure it out so these people didn't have to, pay for them themselves, But Indian Health does kick in once in a while if there's a problem. But yeah.
Thank you, Marie. Dr. Bianco, do you have anything to note on that question?
Yeah, so the coverage of medications is highly complicated based on insurances and that. We do know that for our BIPOC population, our Native population, that there are huge disparities in regard to chronic disease, and that in and of itself is a challenge that needs to be addressed. The cost of medications is abhorrent at this time, and it is wrong. Insulin has been around for years and years and years, and a smart government would recognize that the downstream costs of untreated diabetes, such as dialysis, such as blindness, such as cardiac disease, such as stroke, it just doesn't make any financial sense. So what it pervades in the healthcare system as we have it right now, particularly in the pharmaceutical industry, and this is my opinion, but I think I can pretty much sum it up, is greed. And our method of funding our healthcare for our country is based on profit, and that leads to this problem. Senator Klobuchar is working quite hard in regard to this, so I pay attention to what's going on at the federal level in order to try to change this around.
Excellent, thank you. And Christy, do you have anything you'd like to add?
I would just like to add on the comment for this sister friend who has the husband with the later stage of dementia and feels that she has no support. You know, reaching out to some of the more formal support networks, even starting with physician of care, asking for any community supports in the form of support groups. The county of residency, the county public health and human services may be a good starting point as well. Senior linkage line. So it's just a matter of trying to get to those supports. I always say it's, you know, you don't know what you don't know when you need those services if you've never had to utilize them before. So the services or supports are likely there, but it's creating that awareness of where those formalized supports are. So again, being an advocate and reaching out to a few of those options might be a good starting point as far as that support role with the dementia.
Excellent. And Megan, I'd invite you to jump in anytime you want.
Yeah, I mean, Dr. Bianco, I completely agree with you. So you can speak for the group if you're counting you and myself in that group. But I wanted to highlight the fact that our state employees, of which I am one, we have a group insurance program. So we are self-funded as a community, which keeps the costs lower. So in addition to what Dr. Bianco said, I would advocate for healthcare for all or a single payer system and move in that direction, which would hopefully either drastically reduce or eliminate that greed that exists in the pharmaceutical industry.
Thank you.
There's another question here, and I don't know if Dr. Bianco wants to take this, but it's on encouraging medical students. How do we encourage more medical students to specialize in elder care?
Right, great question. Thanks for that. Yeah, I'm a assistant professor at the University of Minnesota in Duluth, which also has a focus in regard to our indigenous population, and that medical school has the second highest number of students, indigenous students, in the country. So that's a positive thing going forward. But we're really working hard with our medical schools, even at the high school level, to get people interested in healthcare, whether it be medical school or PA school or nursing school. By giving students exposure and coming out into the rural community. It's incredibly important. I have a student from the University of Minnesota Duluth who comes and stays with me for a week at a time, and we have them see patients and be with us to just understand what it's like to be working in the rural community. I know College of St. Scholastica does the same thing with their with their AP students as well, and with their PA students, I should say. So those types of efforts are really important. Secondarily, foundational money and scholarships in order to get them through their schools are really important. There are federal programs in regard to working in underserved areas as well, in which loans can be forgiven for students. So there's a lot of work going on from that standpoint. also on the front end, and I think the University of Minnesota Duluth has proven this, is that if you recruit and admit from students who are from rural communities, there is a greater chance that they're going to go back. And so I think that's another important aspect of this.
Thank you, Dr. Bianco. There's a question up here from Marie. Marie, can you tell us a little bit about the Wisdom Steps program for tribal elders?
Okay, Wisdom Steps was started back in 2000. And we're supposed to have our 20th anniversary 2 years ago, but at our conference, but we couldn't. And it's working with elders, Indian elders. You have to be 55 to join, and make sure that they get their health checks and everything, that kind of thing. We take them out and for, things to do and keep them busy, and it's great. The conference, they work all year with their they have to have steps, how many steps they walk in the year, and their medical records up to date. And that's about all they do. And so the reward is a conference in June, and we bring them all together and pay for their rooms and their meals and everything. We have a banquet. It's great. We have breakout sessions, and we have people like Dr. Bianco that come and do breakout sessions for us. And it's wonderful. The elders just have a great time. The first night we get there, we have a fun night. So there's games and everything, bingo included, for the elders to have. So they look forward to that all year long, but it's mainly for keeping up with their health and exercise and getting them out of the house. That was a big thing. Before we had Wisdom Steps in Grand Portage, nobody took the elders out, really, except it was their family. A lot of people didn't have family up here. So I think it's a great, great organization. So, yeah.
Thank you.
Mm-hmm.
Yeah, that's awesome. I love the Wisdom Steps program. It's really a value added to our Native communities for sure. So the next question is a little more broad in terms of collaboration. So how do we address the needs when a caregiver/client does not have an advocate and they're brand new to the system? Could a solution be education, how to navigate the resources before it becomes a critical solution? Chrissy, do you want to take that?
Yeah, I'll speak to that one. And I can allude to a couple of things that have worked in our rural community, specifically addressing this. So a caregiver that might be, again, new to the system or new to the scenario of a caregiving role, something that's worked well in our community is we have a referral system set up in place with both of our local clinics, where a caregiver that would be caring for the care receiver with a dementia-related diagnosis or even non-dementia related in that caregiving role, where they are referring directly over to our agency. So the primary care provider is referring over. So we can be a good first point and step of general information for the resources available in our community for that caregiver. And that can be not just services that our agency offers, but what is available in the greater scope of the county, basically. Again, that's just an example of something that's worked well in our community. The other part of the question too is how to navigate before a critical situation. So I think a lot of this drills down to awareness and truly just being aware of what services are available. So how do we make clients aware? How do we make caregivers aware? And again, referring to some specific examples that have worked well in our county, I know that we right now have an awareness campaign going on specifically with our program specialists at our agency, where we have several distribution channels where we are making information known to what services and supports are available, whether that be, at the food shelf or home health care or transportation, other nutrition topics, dementia support. Again, trying to get that word out there through multiple delivery channels. And the other part of that too, I think, is if you don't know where to start with it, obviously, I think the primary care physician is that great starting point, but also relying on some of those other resources too, with the, you know, county public health and human services, the older adult caseworkers. I mean, I collaborate daily with them. So there are starting points to be able to gather that information and feel like that you have a general sense or general knowledge of what those resources are before basically you may need to use them. And I think speaking specifically in the caregiving role, typically for those caregiver clients that I serve, one of the first and most important conversation we have in that caregiving role is the pre-planning component, you know, the healthcare directives, powers of attorney, you know, living wills, those types of things, to try to get the pre-planning in place. So when we do need to implement those plans, that we've been able to make those plans well thought out, within our control, when the care receiver is able to speak their wishes as well. So if we're looking specifically at pre-planning in that caregiving role, that is something as a caregiver consultant that we work directly with as well.
Thank you. Thank you for that. I just want to be mindful of our time here. It looks like we're coming to almost the 1:20 mark. I think, Christy, we have time for one more question, perhaps.
I think we do, but I'm not seeing anything in the chat. Are you seeing something, Amy, that?
I think there's one, I see one maybe that came in. Is population growth at the statewide level always seen as a positive change? Does population growth indicate greater opportunities for older adults? I guess the second part of the question, maybe Megan, if you could comment on that.
I'm so sorry, it cut out there in the end. If you could just repeat that part of it for me.
Oh, I'm sorry. Yep. So the question is, does population growth indicate greater opportunities for older adults?
Oh, population growth. I don't think I can answer that definitively, because it depends on where people, I mean, we're experiencing population growth right now in Minnesota, 400,000 people over the last 10 years. And I don't know that we can directly attribute, or we can directly correlate that with better care for older Minnesotans. Certainly there's more people thinking through the problem and solutions to the problem, you know, but we demographers have been shouting for the mountaintops for decades here, saying there is this huge wave of people coming that we have had to change society and infrastructure to accommodate all along the way. And they're going to reach retirement here pretty soon. And then we're going to have to talk about healthcare, you know, and it seems that we continue to be reactive rather than proactive. So I think that's the real issue here, that population growth, no, I don't think that directly translates to better care. I think proactive solutions to problems or challenges, I suppose, that we know are coming are much more important than the number of people working together to solve the problem.
Thank you, Megan. And just, there's one more question here. Are there any statistics on how many of those 65 plus people are still in the workforce in Northeast Minnesota?
I assume that's a question for me. Feel free to jump in, anybody else that wants to answer that question. But we are seeing folks stay in the workforce longer now than they did about 30 years ago for the same ages. So it's not the same people, right? It's the retirement age people are staying in the workforce longer than they used to. Again, I don't know that that's necessarily a good thing in general. It means that retirement options are not able to support people when they would choose to retire maybe. It also means that maybe people really like what they're doing and they want to stick around. So we do have those numbers. I don't have the breakdown for particularly the 7-county Arrowhead area, but we can see that folks are staying in the workforce longer statewide in Minnesota in general. And if folks are interested in pulling those numbers out specifically for the Northland region, I'd be happy to pull those numbers for you offline.
Excellent, thank you.
Yeah.
Amy, are we doing okay on time? I see one more question from Marie.
Okay, yeah, we're just at the 1:21 mark, so maybe one final question, if you want to pose that, and then probably transition into our closing here.
This is a quick one, Marie. I hope it's quick and easy. Someone is inquiring about the dates for the Wisdom Step Conference and asking if it's still going to be held this year.
Yes, it's going to be on starting June 13th through the 18th. To the 17th. It's going to go 2 days longer this year. It's usually 3 days, but why we decided to extend it a little bit. You know,
Excellent.
got a lot of people going. When I first joined Wisdom Steps, we had 113 members out of 11 tribes. Now we're up to just about 600. So that's pretty good.
Oh, that's fantastic.
Yes.
If Marie doesn't mind, we'd be happy to post the dates for that on the website, along with some of the other resources you'll find.
Sure.
Yeah, so I just want to thank all of you panelists today, and just note that there are a number of resources available for aging related questions in the Arrowhead, including calling the senior linkage line at 1-800-333-2433, connecting with your local home and community-based service provider. There's providers in all 7 counties in the Arrowhead. There's minnesotahelp.info, legal aid services of Northeast Minnesota, and a number of other resources that can be found on the website for this series, which is www.ndiaseries.org. And because we're getting close to the end, I'm going to not go into much detail about the resources, but please visit our website and find them there. And I'm going to pass it off to Amy for our final farewell.
Thank you so much, Christy, and thank you again to our panelists for your thoughtful wisdom and inspiring words today. It truly, really was informative and impactful. Thank you to my co-moderator, Christy, for sharing these invaluable resources. And in closing, we'd like to invite you to a call to action. To really think about, some of the key things we can do that we need to better understand rural aging and really understand what we mean by diversity in all its forms, and the responsibility that belongs to all of us in terms of really understanding unique challenges and really closing some gaps. We'd like to challenge you to lean into the unique roles that each of us play in addressing these barriers and understanding the unique and diverse needs of our communities. How can we encourage each other and encourage ourselves to engage and really to bring this new knowledge? So what is the responsibility now with this new knowledge that you can bring to your spheres of influence? How can we do that? And then finally, as part of this engagement, to please attend our next series, our next Diversity and Aging series. And again, I just want to thank all of you for attending this series. And again, a heartfelt thank you to all of our panelists who was with us today, and for that wonderful thought-provoking information. So with that, I just want to thank everyone again for joining us today.